syndrome is commonly seen in reproductive age women. Like 10% of women have polycystic ovarian syndrome, and among these women, like 50% have ovulation problems. When a woman comes with ovulation problems, the first step in initial fertility issues is starting with oral agents for ovulation induction. If the oral agents work and women can ovulate with these pills, then she is told to have a sexual intercourse at a planned time. And if she cannot get pregnant in 3 to 6 months, then the treatment management is changed to injectables, which will also induce the ovarian egg stimulation. In the second step of this fertility treatment in polycystic ovarian syndrome cases, very low dose of gonadotropins are given for daily injection to these patients, and these patients are followed up at ultrasound. And if we see the follicles, then we trigger the ovulation, and the patient can have an IUI treatment or again planned sexual intercourse. If pregnancy is achieved in these first two steps, then the patient is happy. If not, then we start with the IVF treatment. IVF treatment in polycystic ovarian syndrome cases is a little bit different than other women because these women have very high number of eggs, high number of follicles, and their hormone levels, AMH levels, are really high, nearly more than 3.64 nanograms per milliliter. With these high hormone levels, AMH levels, and high follicle counts, the risk in IVF cases in polycystic ovarian syndrome is ovarian hyperstimulation syndrome. This syndrome comes with high estrogen levels and many follicles retrieved at egg pickup. That is why polycystic ovary syndrome cases IVF treatments has to be planned considering the risk of OHSS. In these cases, we start with low dose of gonadotropins, starting on day 2 to day 3. We give very low amounts of gonadotropins, like 100, 150 units per day. And we usually use antagonist stimulation protocols, or we use progesterone prime stimulation protocols. Then we follow up, during the follow-up of these ovarian stimulation cases of polycystic ovarian women, we call them more often for the ultrasound. Normally we call the IVF cases every 2 days. But in polycystic ovarian syndrome, in 1 week, we might call her every day for ultrasound, and we might do the blood test for estrogen levels every day or every other day. So in order to control this follicle growth, we just follow up the case 7 to 10 days, and when the follicles are ready, everything is okay, the estrogen levels, the follicle sizes, everything is ready. The next step we do in order to inhibit this stimulation, ovarian hyperstimulation syndrome, we do analog trigger. In order to just not to have the ovarian hyperstimulation syndrome, in these cases, we give the patients GnRH agonist trigger. We don't give them HCG trigger. If you do the HCG trigger in these cases, then ovarian hyperstimulation syndrome is like 1 to 10%. It's really high. But if you do the GnRH analog trigger in these cases, then the ovarian hyperstimulation syndrome is less than 0.1. So it is very safe with analog trigger treatment cycles, polycystic ovarian syndrome cases. We do the analog trigger, and the next step, what we do in order not to have the OHSS, is total freezing. These patients have many follicles. At the egg pickup, they usually give more than 15 eggs at once. So if we have more than 15 follicles, 15 eggs, then we freeze them all. We don't do the embryo transfer. We do the embryo transfer 1, 2, 3 months later. The earliest time is like 1 month later when the new period comes, but we do the total freezing procedure in order not to have the risk of ovarian hyperstimulation syndrome. These are the basic criteria. Everywhere in the world, we just apply these rules to polycystic ovarian cases. But as these cases have very good count of eggs, they are lucky at IVF cases because the more you have eggs, the more you have the chances of having a baby. Another issue related with polycystic ovarian syndrome is about the egg quality. Usually, polycystic ovarian women are overweight or obese. If you are having these problems with insulin resistance and all, you might have an oocyte factor in IVF cases. These patients might have worse oocyte quality and embryo quality. And it's well known that obesity is a negative risk factor for pregnancy chances in IVF cases. Before starting the IVF, if you're having polycystic ovarian syndrome and if you're overweight or obese, it's better to lose weight to have better success rates, and this will help you. If you're having insulin resistance, if you're having diabetes in accordance with the polycystic ovarian syndrome, you better have your blood sugar regulated, because when you get pregnant with IVF, high blood sugar, high glucose levels cause congenital abnormalities, miscarriages, intrauterine death of the fetus, so it's very important. Polycystic ovary syndrome is not a reproductive problem only. It comes with all the metabolic problems itself. So the metabolic problems related with polycystic ovarian syndrome has to be corrected before the IVF cycle, so you will have better test results at the end of the IVF treatment cycles. Polycystic ovarian syndrome cases as we said, have many eggs retrieved, and these, if the sperm is also good, at the final step before the embryo transfer, the patient may have many good quality embryos frozen. At the embryo transfer, you will have 1 or 2 embryos transferred to you. You can keep the rest of the embryos frozen for many years. So from one cycle, you can have 1, 2, 3 or more kids with those frozen embryos. This is also a good chance for you. Polycystic ovarian syndrome, IVF is the highest chance success rate patient group if the woman is young. So don't be afraid of the risk related with polycystic ovarian syndrome. You have a high success rate. Please contact us if you have further questions.